So Dr. Wade is a medical oncologist, a medical director at the Melanoma and Skin Cancer Institute and Sarah Cannon Research Institute at HealthONE, coming to us from Denver, Colorado. And he'll be presenting on Immune and Cellular Therapy 101. No easy topic, but looking forward to your discussion, Dr. Wade.
All right, excellent. Well, thank you to Dr. McKean for the introduction and hosting today. Thank you, everybody who's participating and joining from around the country. And Dr. Armatruda, thank you for the excellent preface to this immunotherapy talk. And then we have Dr. Yorio coming up thereafter. So I'll certainly do everything I can to stay on time today. It's a pretty significant task, I think, to talk about immunotherapy and melanoma from start to finish. And I don't think that's the goal today. I think the goal is really to talk about the mechanisms that we think of when we're using immunotherapy and melanoma and even other types of cancers. And so I'm really going to focus on the key principles in terms of how our most common therapies are used. And I also want to talk a little bit about adoptive T-cell therapy, which is recently approved for the treatment of melanoma, as we'll talk about. But also, there's a lot of growth and development in cellular therapeutics in general, which includes adoptive T-cell or TIL therapy. So we're going to focus on those two topics, really. And I'm happy to give this today because this is one of my favorite, I guess you could say, lectures or talks to give, especially to medical students, residents, and fellows, and people who are in training and first learning about immunotherapy. So this is a brief comment and a little bit outdated, but I think it's pertinent because this is from 2015. And so if we look at melanoma survival, even back as recently as 2015, let's call that 10 years ago, you can see that the overall survival at 5 years was still fairly low at that time, even after the approval of some of these newer immunotherapies, and other cancers really had a very low survival rate once it was metastatic. And so this was one of the driving forces behind all of the developments that you've heard here already today, immunotherapy and targeted therapies included. If we look at the cancer treatment modalities we have available to us, we have chemotherapy and targeted therapy. And targeted therapy, Dr. Armatruda just gave us some insight into. We have radiation, we have surgery, we have immuno-oncology. These are all separate approaches and separate treatments that I think should be thought of as such, but can be used in combination in a sort of a multidisciplinary approach to treatment of cancer care, including melanoma. So we're going to focus on the lower right puzzle piece, which is the immuno-oncology piece today. So when we talk about immunotherapy, that term gets used a lot, and it actually encompasses a wide variety of topics. As listed here. And I think it's easiest to digest when we separate it into two categories, active immunotherapy versus passive immunotherapy. So active immunotherapy is going to be things like vaccines and cytokines. And we're going to talk specifically about the one on the right, which is an immune effector cell modulating therapy or immune checkpoint blockade. That's really what we're focusing on in terms of our mechanism of action, because that's what we use the most of in our clinical practice. And then the passive immunotherapy is certainly not to be ignored. Very important. This would include, these treatments are not designed necessarily to act directly, or are designed, to act directly on the tumor as opposed to the immune system. And so that would include our adoptive T-cell therapy or our TIL therapy, which we're going to talk about. So the two we've highlighted are what we're going to talk about today. This is a fun cartoon that I like to use to sort of highlight where we've come from in immunotherapy. So going all the way back to 1891, we have documentation of the first cancer vaccine, in quotation marks, demonstrated by Dr. Coley when he was essentially injecting bacterial toxins into patients that had mostly visible tumors or cancers, because things like X-rays and that sort of thing were not widely available or developed at the time. And he noticed that these tumors that could be visualized on the skin would sometimes get better if you injected these patients with bacterial toxins, or essentially infecting them with bacteria. And what we now understand, although they didn't understand it at the time, is that we were inducing an immune response. Our immune system was responding to the bacterial injection and was then cross-reacting, if you will, or better equipped to fight the cancer at the time. And so there were some successes with that approach early on. And then you can kind of just read through as we've moved into the 1960s and interferon in 86, and then a prostate cancer treatment in 2010, which was really the first cellular immunotherapy that was approved. And then 2011, starting in 2011, brings us into the modern era, if you will, of immunotherapy with the approval of ipilimumab in melanoma. And melanoma has really led the way for a lot of these developments, and led the way for other cancer types. So this really talks about, this is just highlighting some of the articles at the time when these immunotherapy, immune checkpoint blockades were first being developed. So it was in Time magazine, and it was the breakthrough of the year in Science magazine. The person on your top, the handsome gentleman, I should say, on your top right, is Jim Allison, who was a pioneer in the development of these immune antibodies, specifically CTLA-4, and went on to win a Nobel Prize for his work. So this is what I really want to get to. This is the educational piece, kind of talking about how these work. And I don't know if people on the call have heard some of this before, but we really have to understand the immune system. So two different types of immune response. There's an adaptive response that comes in a little bit later after the initial insult, if you were to have, say, a bacterial infection or pneumonia. Then there's innate immune response. So the one that comes in initially and you get that initial increase, and that's maybe fevers and chills and flu-like symptoms and not feeling very well. It's really the adaptive response that we want to focus on. That's when we're creating our antibodies against, these pathogens, whether it be bacterial or viral infections, for example, or we're expanding our T cell populations to better fight these infections over the long term, and even to recognize them into the future and prevent them from reoccurring. So these T cells come in two different flavors. We're going to focus specifically on the T cell component. You have cytotoxic CD8 T cells, and you have helper CD4 T cells, and those are our main compartments. Both of these cells, these two different T cells, CD4 and CD8, expand in response to a stimulus. Again, I'm going to use a bacterial infection as a very common stimulus. And so they clonally proliferate. They basically make clones of one another, and they expand out in both of these two cell populations that are then eventually controlled once the infection or the insult is under control. And that's how our immune system responds to various types of insults. And in a way, it's how it responds, or how we need it to potentially respond to the growth of a tumor. And so this is a little bit more complicated slide, but I'll focus on the 2 points on the right. The human genome, just to put this into perspective, has about 20 to 25,000 genes. That's a lot of genes in the human genome. But the number of things, the number of items or proteins, let's say, that the immune system can recognize is nearly nearly tenfold that. So 10 times the amount of genetic code that we have, or genes that we have, are the number of receptors that the immune system can create or generate to recognize bacteria, viruses, etc. So the success of our immune system against an infection or against a tumor is really predicated on how diverse it is and how much it's able to recognize, or in some instances, when we talk about cancer, unfortunately not being able to recognize the cancer as foreign. And so what happens when our immune system is activated is that a professional antigen presenting cell, so a cell that its sole purpose is to present an abnormal protein from a bacteria, a virus, or a cancer cell to the immune system. So those are things like our macrophages and our dendritic cells. And that's what the professional antigen presenting cells are meant to do. That is their purpose. This little red dot here in the center shows the protein that's being professionally presented by one of these immune cells to another immune cell, CD4 T cell on the right, CD8 T cells on the left. And this schematic is just highlighting there's some functional differences between the two in how they're recognized and how they're presented. So here you see the same cartoon. And so what we see here is that the initial recognition of that little red dot, that protein, we're going to call that signal number 1. That's a T cell receptor signal. So that's receptor number 1. The key in understanding how immunotherapy works in cancer is understanding that you have to have a signal too. You have to have two signals to activate a T cell. You have to have both. What you can see here is that if you only have one signal, the T cell is anergic, it's not active. If you just have the second signal, it has no effect on the T cell. You have to have both in combination. So it's signal 1 and signal 2 that's needed to activate the T cell. Now, if you have both signals, the T cells proliferate, like I showed you, clonally, they increase in number, and then they become effective to attack whatever they're trained to recognize. So that's what we call effector function. So it's attacking, in this case, virus-infected cells, but the same concept applies for cancer cells. So just imagine these viral infected cells here on the right being cancer cells. The immune system is going to that site, recognizing them as foreign, and eliminating them if both signals are present. So here's the trick. So the signal 2 is not just a single signal. It's actually thousands or hundreds of thousands of signals that are constantly interplaying, tugging, pushing, and pulling on the immune system. So back in 2002, where this cartoon came from, we understood a number of these interactions that made up signal number 2. And you can see the effects are either positive or negative on or unknown on the immune cell. So this is what we knew in 2002. Fast forward to 2015, and we understand that there's actually thousands of these signals that are constantly at interplay with the immune system at the level of the T cell. So what it becomes is a summation of how many positive signals you have versus how many negative or suppressive signals that you have on your T cell or on your immune system. And so it's a balance between the brake and the gas in terms of how active the immune system is, that would be turning on the gas, versus how inactive it is, and that would be pushing the brakes. So it's a really, really complex system. And so here's a schematic of a T cell, one of those immune cells, interacting with all these different, here's your professional antigen presenting cell, here's your tumor cell, and here's your macrophage, which is another antigen presenter cell, professional cell. And so the T cell can be acted on by all these different factors all at once. But we have gathered or developed drugs that can block some of the negative signals that make up signal number 2. So you see these red X's appearing. These are some of the interactions that we've developed, antibodies or drugs, which block that handshake, which block that agreement between the T cell and the tumor to not be active against it. And so if we block enough of these negative or down-regulating pathways, then the T cell or the immune system is able to be more active than it would otherwise. And that's the concept of the gas and the brake. So balancing the gas and the brake. You want to have, in terms of cancer treatment, you'd like to have a little bit more of the gas, a little bit less of the brake. So what we're actually doing is we're eliminating or pulling back on the brake on the immune system and allowing it to be more active by blocking some of those negative signals. So that's the way we should really be understanding how these immune checkpoint blockade drugs, which have been developed and available since 2011, are working in melanoma and other types of cancers. So when it comes to tumor cells, here's a cartoon of how the PD-1, the T cells interacting with the T cell. Here's your signal number 1. Here's the protein presented to the T cell on the tumor. And then here's that negative signal number 2, the PD-1 interacting with the PD-L1. And again, that's an agreement between the tumor cell and the T cell to shut down the function of the T cell so that it can't attack the tumor. But if we block this one interaction here with an antibody, that being the little red triangle, then the T cell is able to recognize the tumor cell and kill the cell. So that's the function of these treatments, and they work really well. People like to see pictures. Here's a CT scan of a patient with tumor, which is this big sort of conglomerate mass here that we see. And here's another tumor that's quite large in the liver. The rest of the things you see here are actually normal. And after treatment with a number of immunotherapies that we just talked about, you can see that that big mass has disappeared completely, and the liver mass has also disappeared, no longer present. So these can be very effective treatments for certain individuals with melanoma, such as in this case. So if we look out to where we are today, This would be sort of our landmark study that looks at the combination of two of these immune checkpoint inhibitors and how we're doing 6.5 years out after the initial treatment with these two immune therapy drugs that we just talked about the mechanism of. This data has since been updated to 10 years, and I'm just showing you the 6.5 year, but it's similar, I will say, at 10 years out from treatment, which is really remarkable. But what we're seeing here is in the very top line, the very top curve, this is essentially saying that half of the patients who received this combination of immune checkpoint blockade or two immune therapies together at the diagnosis of their melanoma, that would be metastatic melanoma, those that need treatment and can't be removed surgically or treated in other ways, we see that 50% of people are alive and in many cases doing very well out 6.5 and then further 10 years out from their treatment, which is quite remarkable. And the other lines that you see here, this is a single immunotherapy drug used by itself, 42%. People do pretty well there. And then this is another single immunotherapy drug. The red line is when you combine the two together. And so we're really doing quite a bit better than we were with melanoma a number of years ago in 2015, as I showed you in the beginning. This pie chart that I'm showing, I think, is important. And there's only one point to take away here, really, and that is that the blue portion of this pie chart are the patients that are treatment-free. So that means the patients are off of treatment, in this case, 6.5 years later, and are alive and well after the treatment. So you can see the blue on the left hand in this pie chart makes up the majority of the pie chart. So that's patients that are off of treatment after receiving that combination immunotherapy. So not only are they living a long time, but they're also off of their treatment in many cases. So let's put it into perspective. Let's see where we're at. So historically, these are the number of patients that were living with melanoma that was metastatic a number of years ago, as recently as a decade. And you can see that that's not many people out here 10 years that are alive with melanoma. Well, when we started treating with the single drug, ipilimumab, we see it increased to 20% out at 10 years. That's really great. When we look at our PD-1 inhibitors, let's think about that as maybe the next generation of immune therapy. Nivolumab is a good example of this. When we look out at 5 years, we see about 35 or 40% of patients who are alive and well. And when we combine nivolumab and ipilimumab, we see out at 10 years now that about roughly 50% of patients are alive and well. But we still have an unmet need here for the other 50%, right? Those who are needing other treatments or maybe who aren't living as long. And so in the future, we hope to be closer to 80% and even 100%. And that's where things like adoptive T cell therapies and other clinical trials come into play, looking to see how we can do better. So I think I only have until 10:30, so I'm going to skip over the complications of immunotherapy. But just to say that side effects from these immune drugs have to do with activating your immune system as well. And I always tell patients that in the clinic before we start, that when you activate the immune system, we hope that it recognizes the cancer as foreign and eliminates the cancer. But it can also become confused, and it can attack healthy organs in the body and cause inflammation in healthy organs in the body. And so these next couple slides, which I'm going to skip over, tell you about some of the side effects that we see with these medications and the incidence of those side effects. It also would tell you a little bit about what we do and don't understand about the side effects, because we're still learning a lot about how the side effects occur. We understand what the side effects are, and we know how to treat them very effectively. We're still trying to figure out who gets the side effects and who does not, because not everybody has the side effects from immunotherapy. But I'm going to skip over a couple of these slides because of time. And I'm going to move into TIL therapy, because I think that's important to talk about and to touch on. And it's sort of a hot topic right now. So if we look at how TIL therapy, adoptive T cell therapy, works, remember, this is a passive immunotherapy. So this is not acting on the immune system quite as much as it is acting directly on the tumor, but using the immune system to do so. So the way that this is done is we excise the tumor. And in this case, we're excising about 1.5 centimeters of tumor. So it's a small piece. And we put it in a plate or separate it out. We grow out the T cells, and you can see that we can assess for which T cells, which immune cells are in the tumor, and how they differentiate from one another. We can then select for specific T cells that we think might be best acting or most likely to act against the tumor in other locations. And then we can expand or grow those T cells in a lab and then use them to treat other areas of melanoma in this particular case. So the process for this is outlined in this schematic. So the journey or the patient journey for TIL or tumor infiltrating lymphocyte therapy is that you have the 1.5 centimeters of tumor collected. We just saw in the last slide this process, how the T cells are selected and expanded. And then the patient undergoes in hospital, often it's in the hospital, a 5-day chemotherapy treatment, which reduces or knocks down the immune system initially on purpose so that we can give the patient back the T cells that were pulled out of the tumor. So it's a really sophisticated treatment. And then this IL-2 administration is when we stimulate those T cells, those immune cells that we just gave back to the patient. We stimulate them so that they can better activate against the tumor in other locations other than where it was harvested and in the location that it was harvested as well. So I'm going to skip over this lymphodepletion, but when we use TIL therapy, this is a picture of a tumor just sitting underneath the skin. So that's that bump before TIL therapy. You harvest the tumor, as we talked about, and you treat the patient in the way that we just outlined, where we give the T cells from the tumor back to the patient in an expanded form. You can see that there are very rapid responses in tumors that were previously very hard to treat, and this is a melanoma patient. So here's a picture, because we always like pictures. This one's a little bit harder to see, but this area circled is the tumor. All the other things you see here are normal organs. And 5 years out from treatment, this particular patient has what we would call a normal area of scar from where the tumor previously was after TIL therapy. So it can be very effective, again, for some patients. If we look at how effective it is, this is the original top-line data for the TIL therapy. This is what was initially presented pretty early on. And what it showed was that a number of patients, and what you see here in this waterfall plot, those on the right, any bar that's below the 0 here are tumors that are shrinking in size or decreasing in size, and everything up here on the left that's increasing in size, that would represent a patient that maybe isn't responding to the treatment or the tumors are getting larger. And so we call this a waterfall plot. And in this particular instance, these patients were melanoma patients that had received many prior therapies, including immunotherapy, before receiving TIL. And those individuals sometimes did not have many other options outside of a clinical trial. And so on this particular clinical trial, you can see that the response rate is pretty good. A lot of these tumors were shrinking down. In fact, about 81% of patients had a reduction or decrease in their tumors. And this therapy, based on this data and some other data, was approved February 16th of this year. So just recently approved and starting to be available widely outside of clinical trials at certain centers that are capable of providing this very complex treatment. This just highlights that about half of the patients, or maybe a little less than half the patients who have a nice response, have it ongoing for a long period of time, and without recurrence of their tumor or without regrowth of their tumor. And so there's some durability here. This is a busy slide, which I won't go over in too much detail because I'm a little bit over time already, but we're moving this TIL therapy up to the front line. What I just showed you before were patients that were already treated with a lot of other treatments, usually immunotherapy. In this particular trial and things that are forthcoming, we're actually looking at what if we give the TIL therapy, the adoptive T cell therapy we just reviewed, earlier on in the patient's treatment journey. What if we give it in the first line before they received any other treatment? And so you can see in the top left, these, again, another waterfall plot. These are patients who are responding to the TIL therapy prior to receiving any other therapy. And so this is a proof of concept for treating patients maybe a little bit earlier with TIL therapy, and also in combination with one of our other immunotherapy drugs as well. And so trials looking at that approach are ongoing currently, and just sort of activating as we're giving this talk. This is my last slide on TIL. And so this is just highlighting a newer version. Maybe we could refer to this as TIL 2.0, something along those lines. where we are taking those same T cells out from the tumor that we just described, or removing them via a biopsy or via surgery. But in this case, we're actually modifying the T cells. We're not just growing them in a petri dish in the lab and giving them back to patients. We're modifying them ever so slightly. And we call that genetic engineering, or changing the function of the T cell, which our technologies today, which are fairly sophisticated, allow us to do in a very precise manner. And so why would we do this? Well, number one, we want the T cell that we're giving back to the patient to be more effective. And so this is one way to potentially make it more effective. But moreover, we want to try to reduce the side effects of our treatments. And this particular engineered T cell is aimed at reducing the side effects from the IL-2 that we give after the TIL has been delivered. And so this is a really, really, I want to say cool, for lack of a better term, this is a really interesting approach where we can reduce the side effects from the TIL therapy by turning the T cells on and off by using a little switch that we put into the T cells. And so we can turn them on to help them recognize the tumor. And then when the side effects become too much, we might be able to turn it off. And I think that's a really, really sophisticated approach, and more to come on all of these treatments, but really exciting in terms of what we're moving towards. There's lots of clinical trials. This is just a list of a few of them that are currently available. The transplant and cellular therapy locations that Sarah Cannon Research Institute offers are listed here. These are where we are currently providing TIL therapy or similar types of therapies. So you can see Denver, Nashville, Texas, and also Cincinnati included. And those are might be resources for people on this call, or people that you may know. And so sorry for going over just a few minutes, but I hope that that was helpful in terms of education around those two topics. So thanks so much for the time.
Fantastic. Thanks, Dr. Waite. I think cellular therapies I feel like just the tip of the iceberg of where we are and where we want to be for patients. And TIL, with the recent FDA approval, I think there's still so much for all of us to learn and for patients to be able to be educated on. So I think that was really helpful.